All right. Well, people can start moving to the microphones if they have questions. I'm going to start with just one moderator prerogative question. So we've heard a lot about the gaps in the research that are there and that we need to fill. What, if any, changes to sort of the current process of doing research or of funding research or of soliciting research do we think will need to change in order to be able to fill those gaps?
I have a couple. Funding. I think funding is really important, and I think, if we want really rigorous research on social needs and how to address them, we need rigorous funding like we give to other health and medical factors. And, one barrier, particularly from the vantage of an academic medical center, which is where I sit, is that the NIH, by and large, is arranged according to kind of disease or body systems. And that's not really how social needs work. And so, like Seth in his research has kind of focused on diabetes and food. I've focused on substance use and homelessness, and if there were kind of more unified large-scale funding, that might be helpful. And then I do think that there's a role in Siren has been good at this so far, of just bringing people together to come up with some sort of consensus guidelines around what measures should we be using, what outcomes should we be prioritizing, and just kind of now is sort of the time, because this is sort of still early days in this research, and so it would be good to kind of all get on the same page now.
And I think there's a kind of backing up a little bit, in addition to learning more about what works in a clinical sense, I think the question about what works as an implementation device. So the wrong pockets problem, internalizing externality problem is well known, and the approach that was brought up, that the Nichols and Taylor model for using sort of economic theory to generate willingness to pay, that's a great theory, and economists, agree that this should work. But I think there needs to be a lot of research to see whether it actually is a feasible mechanism. And I don't, as far as I know, I mean, they've got Len and has got interest from communities in wanting to try this, but I think the money to study whether this is an effective tool for widening this circle of return, I think that's research that needs to be funded. Otherwise, we're still going to be stuck in this wrong pockets problem if there's no demonstrated solution.
And this is Caroline. I don't know if you all can hear me. I'll take that as a yes. I would agree with both of what's just been said and just add two things. I think around the shared outcomes piece, I do think that's one of the things that could really accelerate learning in this field if there were more, if studies included some outcome, the same outcome, so that we could do more comparative effectiveness and more comparisons across studies. And this is something that funding agencies could help encourage or even require. I completely agree with Kelly's point about the way in which funding is currently structured at NIH, and the fact that it's disease-specific makes this kind of research particularly hard. And then I think the other thing that I would lift up is that there is a huge amount of learning happening right now in health systems across the country that is not being synthesized and collected, and it's something that we think about a lot at Siren, but haven't really, I think, come up yet with a great way to capture it better, particularly around, I think, the implementation lessons learned. How do you do this? How do you fit this kind of thing in a workflow? Which staff members are best at doing this? Which type of staff members? And so I think that we need to do a bit more thinking. I don't know if it's some kind of a social determinants practice-based research network or something to really help identify what's being learned and lift that up for more broad dissemination.
Could I just add on to that, that there is so much experimentation, innovation, investment going on, and there's some very exciting evaluation work with the North Carolina demonstration and some of the other large CMS accountable health communities, but that pales in comparison to what's being tried. And there just isn't the level of investment in research or even the attention to setting up the interventions in such a way that they could yield robust insights about impact. So I think we've gone through a period of letting a lot of flowers bloom, and maybe it's time to make some bets and put some serious research dollars into assessing impacts.
I would add one more thing, not to be a downer, but even if we were to come up with the perfectly designed social needs assistance intervention that reduces population levels of cholesterol or something and cuts has a sort of effect on development of heart disease, I think we may still be in a situation where, fundamental cause theory tells us that this is kind of a game of whack-a-mole, that we can solve one problem. We think we can solve one problem, but if the real cause of the disparity in health outcomes for people with and without social needs is not the social need itself, but the lack of resources to fill needs on one's own, we're not going to solve the health disparity problem by intervening in a very targeted, well-designed, RCT-approved intervention, because something else is just going to come along and rise up to take its place.
All right. Any questions from the audience? We're getting close to time. Go. Yeah.
Hi. Sorry. This might be better for some of the panels that happened before lunch, but Dr. Doran's comment actually made me think of it. So you said that there's no intrinsic value in lowering LDL, for example, but there's intrinsic value in giving someone housing or food security. And I think that's an assumption that we all make in this room, but that's not necessarily an assumption that a lot of people think. A lot that goes against a lot of thinking, especially with people who hold the purse strings, right? That people need to pull themselves up by their own bootstraps, things like that. So what is the value, I think, of doing research on messaging of social determinants of health? What works, what doesn't? Maybe that's part 2 of a workshop, but that's just something I wanted to throw out there.
So I'm just going to step way out of my area of expertise because it's late in the day and say I think that's a very interesting observation to put on the table. But I also think I'd like to see more of a roadmap for what works to drive political change in terms of the resource inequities that are profound and have been growing. So I'm interested in the theory of change and the role that research and evidence plays in that equation.
Yeah, and I think that your point actually, I thought you were going to make me answer a question about LDL cholesterol, so I'm relieved about that because I'm just like an ER doc. But I think your larger point that not everybody thinks that we should be giving actually people that need housing is valid. And so actually that is, I think, where there is a role for showing, okay, but if we do that, then, maybe their health improves. Maybe we do have, monetary savings in the healthcare system. And so, that's why I haven't wanted to, for example, just like throw away the idea that we should try to prove an ROI case to the healthcare system for interventions like housing, because I think that for different parties, you need to make different arguments and different things are going to move and drive different people. And I think your point highlights that.
And if I could, this is Caroline, I wonder if I could jump in here for a second again, because I think that this relates back to the framework that I shared at the beginning of my presentation with the different range of activities that the healthcare sector can engage in, and the last 2 boxes that were on the right-hand side that I didn't talk about, but I think as part of what's been coming up that Tim and Jenny brought up, and that this last speaker also brought up, which are the fact that I think everybody pretty much agrees that identifying people with social risks in a clinical setting and helping connect them with resources is not going to be enough to really fundamentally change the health inequities that we have in this country and the poor health outcomes that we see, particularly amongst the most vulnerable. And so I think that's why the National Academies panel, the larger committee, has included these community-level activities as part of this framework to make clear that just doing the patient-level work is not going to be enough. And in terms of research gaps, this is actually an area that we at Siren are increasingly turning our attention to, the research evidence behind healthcare sector activities at the community level, the ways in which health care organizations are often really powerful economic drivers in their communities, and there are a number of healthcare organizations across the country that are looking at ways that they can use their reserve dollars to invest in economic development and low-income housing development or affordable housing development, and looking at their procurement and their staffing to really try to have as much of a health impact as possible. And then there are all sorts of ways in which healthcare organizations can be advocates and proponents of both local and state and federal systems change to address the underlying social inequities that are creating the health-related social risks that we're seeing among patients. And that's a whole area of research, I think, where there's very little that's been done so far, specifically around the impact of the healthcare organizations as advocates, for example, the power of the white coat coming to Congress and advocating for more affordable housing, as the Health Anchor Network did last month. I think that those are all areas that we're hoping to see more work in, and that Siren is certainly going to be we're going to be trying to help explore it as well.
All right. So I think we have time for one more last quick question in this session. Are folks over there trying to ask a question or just standing somewhat near the microphone?
No,
Yep.
I've got a question.
Yep.
Ellen Marie Whalen from CMS Medicaid. First of all, thank you for helping us identify kind of future directions. One of the things that I was thinking, as you were describing, we've got so many states out there that, using their existing Medicaid authorities, are doing home and community-based services and non-emergency transportation and helping to address some of the food insecurities. And so we've got these interventions happening, and they've got the data, and they really could use help doing some research there. And I'm wondering if there's a way that we could help formalize or make more official help with the researchers in the room, helping the states figure out what's working and what's not working. For any of the 1115 waivers, the demos, and our DSRIP, we actually require them to do an evaluation. And I know some of you, including at the podium, have been helping some states do that. But there's so much happening out there now that it would be really great if there would be some way that we could harness some of the research capabilities and helping these states look to see what's working, what's not working, and then that would actually help us figure out how we can scale and spread some of the successful interventions.
Well, we at Siren are definitely on board for that. We're trying to do that to a certain extent, but we would be more than happy to be part of efforts to do that. We try to do that. I mean, we have a network of researchers that are kind of part of the Siren core, and Seth and Stacey and a number of other folks I think that you heard from today are part of that. And we are, we do try to connect folks when there are people coming to us saying we want to evaluate this and who can we evaluate it with. I do think there's some interesting models. I know JPAL has, the folks that do a lot of randomized controlled trials at MIT have a whole program helping to connect people who are in practice settings to folks that can help them do RCTs. So I think that's an area. But yes, we're on board. We'd love to hear other ideas about how to do that.
So I'm excited to hear that. And it feels to me like CMS could not necessarily be a matchmaker, but could help raise up, given your vantage point and your knowledge of all the innovation that's going on around the country, kind of outside of the 1115 evaluation buckets. My guess is there may be philanthropy that might be interested in supporting research, and I could imagine a call for papers, identifying some topics that seem like they're addressable given the innovation that's going on. And that really fits incredibly well with the TMSIS investments that you guys have made. So I think the stars could be in alignment. I think from the researchers around the country perspective, kind of knowing what's going on in a systematic way would be really useful for identifying comparison groups and ways of addressing them.
Just a minor point to add on to that. I agree with what's been said, but the best time to get a researcher involved is before these interventions have started, because they can kind of help decide, how they might be rolled out. Can you roll them out, in a step wedge type way? What to do to make it so that the research is as rigorous as possible, and we're not just left doing kind of a pre-post with like maybe some propensity score matching to try to compare. And then the other thing, just to flip it a little, is I think there's also a role for, how do we get the knowledge that researchers have into the hands of the states when they're trying to decide, for example, what to pursue for their 1115 waivers or their district, because, certainly some states have done wonderful things, and then, certainly I've seen a fair number of things that have been actively disproven as effective in the research. And so, so how do we do it both ways?
All right. Well, thank you. I hope you'll join me in thanking our panel, and I'll turn it back over to Dr. Polsky.